Good afternoon. I'm Kate Moskowski, Senior Manager of Primary Care Systems at the American Cancer Society here in Pennsylvania, and co-chair to the Pennsylvania 80% by 2018 Colorectal Cancer Work Group for Primary Care. And welcome to our first webinar in a series focusing on topics that can help close the gap for colorectal cancer screening. This series is being brought to you by the Pennsylvania 80% by 2018 Work Group for Primary Care, which is part of the Pennsylvania Department of Health Stakeholder Leadership Team. Funding for this webinar is brought to you by the Centers for Disease Control and Prevention. And today's topic is focusing on colorectal cancer screening options, in which you will hear proven evidence on screening options that will lead to the early detection of cancer. This activity has been planned and implemented in accordance to the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through a joint partnership with the New Jersey Academy of Family Physicians and the American Cancer Society. The New Jersey Academy of Family Physicians does designate this as this live activity for a maximum of one AMA PRA Category 1 credit, and we do ask that participants should claim only the credit to the extent of their participation today. I will ask those on the call. There is a survey at the end of this session in which you must complete in order to receive credit. And certainly if you do have questions regarding today's session, you can reach me directly and I will put my information into the chat box. To add, this activity will be recorded and available as an enduring internet for later use. And more information will be coming directly to that after today's call. Also, as this is a series, you will hear more information after today's session about future activities, including a February 21st session for increasing screening rates in practice. So and some of you may be joining now, but there was a slide up in the front in which we do say that all lines, they have been muted and you hear us through your speaker. And so if you do have questions, we just ask that you type into the chat box. So now what I'd like to do is introduce our speaker today. It is Dr. Richard Wender, who is our Chief Cancer Control Officer of the American Cancer Society. He also served as the chair of the National Colorectal Cancer Roundtable and is really considered the spiritual leader of the 80% by 2018 initiative. Prior to the American Cancer Society, Dr. Wender was the chair of the Department of Family and Community Medicine at Thomas Jefferson University in Philadelphia. And just to give a little bit of Pennsylvania insight, Dr. Wender grew up in Pittsburgh and has lived in Philly for 41 years. So please join me in welcoming Dr. Richard Wender.
Thank you so much, Kate. I really appreciate that, the introduction, and it's great to be introduced on a webinar because you get incredible applause, which I can hear through the phone and people in their office. No, seriously, great to be with you, and I'm sure that I have folks on the phone who have worked with before and are friends over the decades as we try to improve primary care delivery in Pennsylvania and in the other states that are participating. Well, this is quite an extraordinary moment for colorectal cancer screening. We have, in March of 2014 at the National Press Club, we launched this bold initiative to achieve 80% colon cancer screening rates by the end of 2018. With the Assistant Secretary of Health, the CDC, and other organizations by ourselves, including the National Association of Community Health Centers who were represented there. Since we've done this, I'm thrilled to tell you that the initiative is making a difference. This is the report from the Federal Qualified Health Center database, UDS. It started reporting in 2012 at 30.2%, and you can see in the 1 year since the launch, it took a 4% jump in colorectal cancer screening rates. Remember, these are the practices that care for low-income, uninsured medical assistants predominantly. So obviously screening is very difficult in that setting, but we jumped 4%, which was the highest 1 year jump in a screening rate that has ever been seen in UDS measures. And it represents an additional 280,000 patients screened in the FQHC system across the country. Where are we in Pennsylvania? Our screening rates are in the second tier, somewhere between 65.9 and 70.4%. Not bad, but certainly room for improvement. If you look at incidence rates, Pennsylvania, because it's an older state, not surprisingly, is in the second highest tier for incidence, and that is reflected in mortality as well, where Pennsylvania is in the second oldest tier. And a lot of that relates to the aging, but it also relates to missed opportunities for screening, that those states that have higher screening rates have lower mortality rates. One of the questions that we've been asked from the start of this initiative is how are we measuring progress? I showed you the UDS measures, but this is the first new national database. This is the National Health Interview Survey data since we launched. And one of the things that we learned, which we didn't quite know when we launched this, and we approved this at the NCCRT meeting in 2013, formally announced in March of 14. But as you can see in the NHIS data, from 2010 to 2030, in most of the subpopulations in the United States, particularly white non-Hispanic, we actually had seen a plateau in colon cancer screening rates. In other words, the people who were motivated and interested in screening had been screened, and those who had not really weren't that interested in being screened. We did see some improvements in some of the non-majority populations, Black, non-Hispanic, a pretty nice steady rise. But in the post-80/18 launch era, we have now gotten off that plateau and have seen a nice increase again in the white, non-Hispanic, as well as a continued increase in the other groups, including a nice jump again in Hispanic, non-Latino. Now, just so you know, we're actually measuring our success not by the NHIS data. Our benchmark is the BRFSS data, which actually will report a higher screening rate as benchmark, and there's some methodologic differences. But that'll be our ultimate report card to see how we're doing. But the good news is in post-80/18, we are really moving the marble. And I think when you realize how difficult it is to get people screened, in my view, this is an extraordinary success. We'll talk a bit more about that later. All right, let's launch into how we're going to do this. What will it really take for the nation to achieve 80/18? And I don't need to tell you, but everyone on the phone, but it's worth reiterating that every study ever done for every screening test shows that by far the chief determinant of whether somebody is screened or not is whether they have a primary care clinician and whether the primary care clinician recommended screening. I think in the case of colorectal cancer, it's not enough just to recommend. You also need to make sure that the patient can access screening and get it done. It's not, colorectal cancer screening is the hardest of all the cancer screens because it demands the most activated patient. You either need the patient to do a prep and show up, and it's expensive, or if in the case of stool testing, they're actually the person, they collect the specimen themselves. It's not done in an office. So you need a very active patient to do this. So given the importance of primary care, what I'm going to attempt to tackle today is how are we going to do that as a primary care group across the nation? What is it going to take to really achieve 80/18? So I've identified what I call 7 basic truths, and here's truth number 1. And I put it number 1 purposely. I don't think there is a more important lesson. This is the single most important in my view. If you're only offering colonoscopy, we know, we've proven this now, that you can achieve very good but not spectacular screening rates. Every large system in the country that is over 80%, and there are quite a few now, is doing it with a combination of colonoscopy and stool-based testing. In fact, most of them rely more than the average practice does on stool-based testing. The highest state in the country who almost uses exclusively colonoscopy is Minnesota, and they're at 70%. And guess what they're doing to try to get from 70 to 80? They're now adding an emphasis on stool-based testing. Now, when you're looking at options, I don't mean to say that colonoscopy is not a terrific option. It is. But both of these options are critical, and you must be organized in a way to offer either one. So let's start with colonoscopy. The reality is that the increase in colonoscopy between 2000 and 2010 really occurred on the backs of colonoscopy. Stool-based testing did not change in that decade. It was a huge increase, 36% increase in colonoscopy rates. So the more people we can get to colonoscopy, the better. By the way, if you do not recognize that this is Captain Jim Kirk, you're too young, and we need to talk. We have a problem. So the Captain Kirk had a polyp found by tricorder and now needs to go for colonoscopy. So here's why colonoscopy is so important. If you have a group of 1,000 unscreened individuals in 2015 and you screen, let's say, 200 of them, in 2016, that 200 is completely up to date. And now you can go after the remaining 800. You get 100 of those and then you have 700 left. But those other people stay up to date for the full decade. So frankly, the more people we can get to colonoscopy, the more likely we are to get to 80 by 18. Contrast that with fecal immunochemical testing, which needs to be done every year. It's only up to date for a year. So if you have 1,000 unscreened in 2015, and even if you screen 500 of those, the next year you have to hit that 500 or another 500 plus 100 more in order to keep the rates going up. So it demands a much more organized approach to screening. You really need a very detailed system to track and remind patients. Nevertheless, we need them both, and I'll show you why. So as important and valuable as it is to get to colonoscopy, we must also be able to ensure that anyone can be offered a home stool blood test. And the rule I use, so I practice still at Thomas Jefferson, not very much now, but still a little bit. And our policy there, because we have easy access to colonoscopy for almost everybody, is that colonoscopy is our recommendation. But if the patient hesitates, we give them a stool blood test. So what does a hesitation mean? Hesitation means, well, I'll think about it. I want to talk to my spouse about it. We'll talk about it next time. That person gets a stool blood test. Once they've gotten a colonoscopy, then they're up to date for 10 years. You do not need to continue to do an annual stool blood test. It's one or the other. There's lots of reasons why people can't get a colonoscopy. And obviously in the uninsured, it's a particular barrier to colonoscopy. So if we use colonoscopy alone, we'll inevitably lead to a screening gap. Here's the good news. I'm sure every one of you has heard the phrase colonoscopy is the gold standard. And if there's one lesson from today's webinar that I'd like you to remember, it's that colonoscopy is not the gold standard. And I say that for two reasons. One is that the quality of colonoscopy varies dramatically, and I'll show you that in a moment. But second, because we've now shown through modeling data that when any of the recommended options are provided as recommended in the case of stool testing annually to average risk patients with appropriate follow-up, and that's critical. That means anyone testing positive gets colonoscopy. If you do it as recommended, you will prevent the same number of colon cancer deaths as you would with a colonoscopy every 10 years. So there is no gold standard. We have a phrase in colon cancer screening called the best test is the one that gets done, and you just need the systems in place to make sure everybody can get screened. Stool blood testing has some obvious advantages, apparent without spending too much time on it. They're cheaper. Anybody in your health team can set a patient up for this. They don't require a bowel prep. I'll come back to this issue of being done in the privacy of your own home. That's a message that really resonates with patients who don't want colonoscopy. They don't want to spend any more time in your office or anybody's office than they absolutely have to. You don't need time off from work, which is a big deal for some patients. You don't need a ride to get home. And obviously, it's completely non-invasive and has no risk. However, a positive stool blood test not followed up by colonoscopy is a disaster. A patient with a positive stool blood test is at 20 times higher risk, 20 times, of having an abnormality at colonoscopy than a person with a negative stool blood test. So to have a positive not followed up by colonoscopy means you have a high-risk patient out there. And so the patient needs to understand going into stool testing that if it's positive, they need to have colonoscopy. And even then, we're not able to get everybody to colonoscopy, but we should be able to get most people to do it. This is a study done out in San Francisco in a federally qualified health center, And their hypothesis is that people would prefer colonoscopy, so they eliminated any cost barrier for these patients. And they randomly assigned people, this was without a cost barrier, no issue of cost, to either getting a colonoscopy or getting a annual stool test. And I think they were probably using an immunochemical test. And they expected that more people would do the colonoscopy, and they found exactly the reverse, that 2/3 of the patients randomly assigned to stool testing did it. Only 1/3 of the patients assigned to colonoscopy actually did the test. I already made this point, a positive stool blood test must be followed up with colonoscopy. Now, which stool test to use? And you'll notice today that I've not talked about hemocults or guaiacs, that I've really talked about fecal immunochemical tests. For those of you who've heard me speak before, either at Rehoboth Beach or at one of our conferences in Pennsylvania, you guys know how long I've been talking about FITs. They've been around for 20 years, but only now are they finally becoming the accepted test of choice. Why are they why do we recommend them over the older guaiac tests? They're more sensitive, they're more specific, they're specific for colon blood. You don't need to change your diet or your medications. They're developed by an automated reader in most cases, so you just get a piece of paper back saying positive or negative. You don't have to hold it up to the light and ask your call and pass them around the office trying to decide if the card turned blue or not. And importantly, although the number of specimens varies, many of them can be done on only 1 or 2 stool specimens. You don't need to do it on 3 in a row. Why do they work so well? They're a completely different testing mechanism. They actually detect human globin, which is digested in the upper GI tract, so that if you have a nosebleed, it will not be positive on a FIT, whereas a colon bleeding is positive on a FIT, but they can be set to be very sensitive. To me, this study from the Netherlands kind of says it all. These were patients randomly assigned to either a FIT test, fecal immunochemical test, or a guaiac test, and you'll see that the FIT dramatically outperformed. And this was with a single specimen FIT versus the 3 specimen guaiac. Much higher participation rate, much higher positivity rate, 3 times as many polyps found, 3 times as many advanced adenomas found, and over twice as many cancers found. So it's just a better test, and if you've not made the switch to a FIT, you should. There are quite a few FITs available in the United States, and the U.S. Preventive Services Task Force actually called out the PolyMedco product, the FitCheck test, as the one that's had the greatest testing in the United States. In fact, although all of these are included, these tests here, Hemocult, ICT, HemeSelect, Ensure, FitCheck, MagStream, have been evaluated in the largest numbers, and the FitCheck probably has the richest database, and that's done on a single stool specimen, and it's distributed by LabCorp. Ensure is distributed by Quest. And they're given to your office for free, no charge to the office. The charge occurs when the patient returns it, and then his or her insurance is charged, or the patient is charged directly. If you're using the really older guaiac tests, like Hemocult 2 or any generic guaiac, they must not be used. They are no longer recommended for colorectal cancer screening by the American Cancer Society or by the task force because they are not sensitive enough. So a FIT, you can use a Hemocult Sensa, and that is a brand name or something that you know is equivalent. That's still a reasonable option, but because it's 3 stool specimens and you need a dietary change, the return rates are lower. Most of you realize that there are now new testing options available. There's the combination of an immunochemical DNA test. There's only one brand name available from that. That's called Cologuard. There's CT colonography, which you may have called virtual colonoscopy. And there's a new FDA-approved blood test, only approved for patients who are not adherent to other options, called Septin-9. And although the task force talked about Septin-9, it did not clearly recommend Septin-9. The ACS is updating their guidelines, so we'll see if that's included. But it's not, in any case, it's not a primary screening option. It's only for patients who are proven non-adherent. The good news is that blood tests are something virtually anybody will do, and that's been proven with this test. So let me just say a word about these new options. Cologuard's been advertising quite a bit. I'm sure your patients have seen it and you've seen it. So a little bit about the FIT DNA. So it's recommended and paid for every 3 years by Medicare and other insurances, even though we don't have data that prove that every 3 years is the right interval, but that's what the manufacturer recommended and that's what's approved for payment. For a one-time test, going up against FIT alone, it is more sensitive. It's also a bit less specific. 92% sensitivity versus 74%. The big deal with FIT DNA is that it's far more expensive. A FIT test is $20. A FIT DNA is $500. And so it can be prohibitive, although commercial payers should cover it because it is recommended now by the task force. It's been recommended by the ACS actually for quite a while. It requires mailing of a whole stool specimen, which some people worried would just turn patients off, but frankly, they don't seem to mind, you know, that you have the bowel movement into a container, package it up as per instructions, and have it picked up. And it seems to work pretty well, and the phone call actually provides patient navigation that the patient doesn't have to pay for, which was a good idea. CT colonography used to be called virtual colonoscopy. I never call it virtual because a patient needs a full prep. Then they go into the office and they have a tube in the rectum, and they're filled with air, and pictures of CT is done. If you ask the patient at the end, now was that a virtual experience or a real experience, every one of them will report it was a real experience. So I like calling this by its real name, which is CT colonography. It's got very good sensitivity for polyps over 6 millimeters in size. Probably not as good for the serrated flat polyps, which is a bit of a concern. It still requires a prep. In mature screening programs, such as the pioneers in University of Wisconsin, patients who have an abnormal CT go right for colonoscopy the same day, so they don't have to do another prep. If you don't have a mature system, the patient has to go home, do another prep, and come back for colonoscopy. And I think that's been the biggest barrier to this test. And the availability of high-quality CT colonography varies around the country. In my view, it's a very good test. It's a $500 test, far more affordable, very sensitive for polyps over 6 millimeters, virtually no, essentially no complications. It's just not widely available, and I think the need to possibly repeat the prep is probably the biggest barrier to it. Okay, those are the options. Let's move to truth number 2. If you only offer screening to patients who are coming into your primary care office, you can achieve very good but not spectacular screening rates, and you have no hope of achieving 80%. So what does it take for a primary care practice to improve screening? You need strong leadership from the very top of the practice, and you need champions, or one champion who really takes charge of the screening program. You have to be able to measure and report, just like all quality improvement, by practice, by clinician, by patient. And you must have a population management approach. You have to contact patients who are not up to date with screening and recall, invite them in, get them involved with screening. You need to have a policy. We're going to do stool blood testing first and colonoscopy only for those who request, or we're recommending colonoscopy first with a backup stool blood test for those who hesitate. But you have to take into account the realities of your practice and your patients. If you're in a federally qualified health center and you're taking care of many uninsured, you're going to have to rely on a stool-based testing. The good news is that's not inferior testing as long as it's done well and done in an organized fashion. Will prevent the same number of colon cancer deaths. You need to provide some form of patient navigation in high-quality screening. The navigation for the colonoscopy itself through the prep and the showing, that ideally should be provided by the colonoscopy group, not by the primary care. But the primary care should get people in to be scheduled and reach out to patients who need to come in. The biggest barrier that we've seen nationally is not having a reliable network of colonoscopists. It's extremely variable across the country. I guarantee you it's extremely variable across the state of Pennsylvania. In Philadelphia and Pittsburgh, and some of the other more urban settings, you probably have a lot of colonoscopists available. That is not true, I guarantee you, in more rural parts of the state. So this issue of a reliable network of colonoscopists is a big deal and is often a reason why it's important to rely on an organized approach to stool testing so you limit the number of colonoscopies. I mentioned this before, but just to reiterate, there are really two forms of patient navigation. Primary care navigation is patient outreach, sending reminders, helping patients solve problems, helping patients complete their stool tests, and making the handoff to colonoscopists. Colonoscopy navigation ideally should be provided by the colonoscopy group with a goal that the patient shows up with a perfect prep and perfect attendance. Unless you think that is unachievable, it is not. Lynn Butterly up in New Hampshire, screening entirely people without health insurance, lower income, through colonoscopy navigation has achieved perfect attendance and perfect prep, and that's been published. I already mentioned this, but it can't be mentioned enough. You'll never improve your screening rates substantially beyond what you've done now unless you have some system to mine your practice data, find the screening gaps, and reach out to patients by letter or by phone, ideally, and get them in for screening. Truth number 3. If you give out FITs or FOBT tests, but you do not track whether the patient returns the test and remind them to do so, your return rates will be poor. You'll be lucky to get beyond 50%. This can be done online. It can be done through manual means, just patient's name, the date given, the date received, and the results. But you need some way to track, ideally through your EMRs, where you can generate a list of orders that were not completed. But it should be routine that patients who receive a stool test get a reminder in a week or two to return that test. And a second reminder will get more people to do it. We've had these tests sit around for a year with patients not completing this, and then lo and behold, 9 months in, they'll do it. So this is hard work. This is what I mean by having a system to increase return rate, and if you don't have it, it won't be so good. I like this idea when you give a stool test out to write a return date on the envelope, return by this date, much like setting a quit date. And I tell patients when I send them home with a stool test, do this on the next bowel movement you have at home, the next bowel movement you have at home. I don't say, do it at some point. I say the next bowel movement, do this test. And the return date is a great idea. Truth number 4. If you ask a patient to schedule their own colonoscopy, but you do not schedule it before they leave the office, only about a half of them will call and schedule. This is a hugely important item. So I won't go through the details of how we did this at Jefferson, but we did sit down with our colonoscopists. We told them what our expectations were, and they developed the systems so that we could make one phone call and hand this over to them, and we made the call from the office because patients will not call on their own. I had a patient not long ago who we found an advanced polyp, and I had a medical student with me, and it had taken a while to get him in. And as I was walking out the door, he said, by the way, doc, I just want you to know if you hadn't called and scheduled, I never had any intention of going. So this makes a big difference. Truth number 5, if you're screening patients with a stool blood test at the time of a rectal exam, it's time to stop. This method does not work. It is not recommended. It is not an evidence-based guideline. It's not recommended by ACS. It's not recommended by the task force. It is not paid for by Medicare. You should not bill this as colorectal cancer screening. If you want to do a rectal exam, you should. That's your judgment and your decision. But it does not constitute screening for colon cancer. These patients need to do their testing at home or have some other test. Number 6, the quality of colonoscopy varies dramatically. And I don't know if you are aware of this or not. But I think you'll be convinced at the end just how extraordinarily variable the quality is. If you look at why people develop a colon cancer between screens, up to 17% of polyps more than 1 centimeter are actually missed. And I'll show you this in a little bit more components. So there's 3 key components of colonoscopy quality: screen the right patients at the right intervals. 2, maximize bowel prep quality and patient show rates. And 3, the most important of all, is to monitor adenoma detection rate. So I'm not going to go through these slides exhaustively. You'll have them available to you. And they're a very important reference. These are what the best data guidelines are now. So here's our recommendations based on family history. If a patient has colon cancer adenomas in a first-degree relative diagnosed greater than 60 or 2 second-degree relatives, you should begin screening at age 40, but any one of the testing intervals is acceptable. If the patient has relatives who were diagnosed at a younger age or 2 or more first-degree relatives, then you should begin at 40, but we recommend colonoscopy every 5 years or even younger. This is also a patient who should be referred for genetic testing for Lynch syndrome. Now, when do you do the next colonoscopy? Because we're doing colonoscopies too frequently. We now know that if the patient has a low-risk adenoma, patient, for example, had a 3-millimeter adenoma, that patient can probably go another 10 years for screening, but certainly no shorter than 5 years. And we see too many of these patients being called back at 3 years. And you can help that. You can make a difference there. Don't approve screening more often than it's needed. Now, there are patients who should be screened more often, but those are people with multiple adenomas or a large adenoma or a villous adenoma or they had dysplasia. Those are patients who need to be screened frequently, and obviously if it's more than 10 adenomas, that's a more complex patient and should be in the hands of a geneticist, in the hands of a gastroenterologist for more frequent surveillance. By the way, if you get a report that the adenoma was not completely removed, that they do have to go back in the next 6 months, and that's been proven. We now even have recommendations for the second surveillance based on what was found at the first surveillance. So if you started with a low-risk adenoma and then you go to no adenoma on the first surveillance, they don't need to be every 5 years the rest of their lives. They can go back to every 10 years. So I won't go through this line by line, but you have the data here showing you what you do based on what you find at the first surveillance. Patient navigation, I've already mentioned this, and I mentioned the work of Lynn Butterly, that she's been able to get her patients down to perfect show rate and perfect prep. The reason why I say this should be the hand of colonoscopy is because they have the financial incentive. This has now been proven that every GI colonoscopy group should have a navigator who gets the patient through the event, because it makes money for the practice because they eliminate no-shows and they eliminate poor preps. And it's cost-effective and it's standard of care. But the most important measure of quality is adenoma detection rate. And if you've never heard of this, hopefully most of you have by now, but some people still are learning this. This is the percent of screening exams with at least one adenoma detected. So for men, this rate should be over 30%, and for women, over 20%. And those are minimal standards. Why is this important? This is a stunning slide. So I'm sure you've heard stories of patients who had, a very rapidly moving cancer. So look at the patient. I boxed the yellow line. These are adenoma detection rates greater than 20%. If a colonoscopist achieves greater than 20% adenoma detection rate, you will not see a single interval cancer between screens for a full 4 years, and then you'll only see one. On the other hand, if you look in the purple line, adenoma detection rates under 11%, the first interval cancer was found at 6 months. So when a patient tells you that I had a rapidly moving cancer because I had a normal colonoscopy and a year and a half later I had a big cancer, that is incorrect. They did not have a rapidly moving cancer. They had a large polyp or an early cancer that was missed. So adenoma detection rate is absolutely critical. And as this study from Kaiser shows, it's extraordinarily variable. Adenoma detection rates at Kaiser varied from as low as 7.4% to as high as 52.5%. So this is now a quality standard for gastroenterologists. This is just showing you the data again. The better your adenoma detection rate, the lower the risk of an interval cancer, the better your adenoma detection rate, the lower your risk of a fatal cancer. This is a critical quality measure. Having colonoscopies done, but done with low adenoma detection rate, misses the entire point. So how does this get better? It gets better the way everything else gets better in quality, and that is to measure what you're doing. So all colonoscopists now should gather and share colonoscopy quality data at the level of hospitals and the level of individual colonoscopists. That's a standard now. That means that they need to have some form of registry that monitors show rates, prep quality, cecal intubation rates, and adenoma detection rates. And you should only be referring, if you have a choice, to colonoscopists who are using a registry and who can immediately report to you their adenoma detection rate. The good news is any colonoscopist in the country can participate. There are standardized colonoscopy reporting and data systems, this is CORADs, that patients can sign up with. This is a report we issued from the National Colorectal Cancer Roundtable about using registries. Truth number 7, surveillance guidelines are not being followed, and you know this is true. Patients are being screened too infrequently. So a patient, just over half of patients who had an advanced adenoma get another colonoscopy within 5 years. At the same time, some of these patients are being screened too frequently because we have patients with no adenomas and no family history who have more than 2 colonoscopies in a 7-year period. So both over and underutilization are occurring, and I think primary care needs to be more courageous and bold to say, we know what the guidelines are, meet with your GI partners, and make sure you all agree that you're going to follow evidence-based guidelines for surveillance. That's what I said in that slide right there. Know your colonoscopists and make sure they're following the guidelines. So let's just take a few minutes as we wrap up here, and then we'll have some time for questions about what you need to do in your practice to achieve 80%. Well, one of the toughest things of all is to know who your patients are. This is so difficult, and many practices really struggle to know who am I really taking care of. If you have a capitation model, and we still have some of those in Philadelphia and elsewhere, it's easier because the patients are assigned to you, they've signed up with you by practice name. Another very common model is patients who had 2 visits within a 2-year period are counted as yours. So you have to use your EMR data, your claims data, and your billing data to figure out who you're really responsible for. The patients must be entered into a searchable database. Frankly, nowadays, this is universally done through an EMR, but you have to have an EMR that can really help you harness data. There are some wonderful population management tools that a large practice can afford and handle. They're not that expensive. They do a much better job than an EMR does. They search your entire practice, and they can spit out a report on the push of a button as to who's not up to date with screening. What is the screening rate for each clinician? They're wonderful. But at the very least, you need to harness the options of your EMR. Takes practice, takes work, and takes some investment. You have to be able to report your population-wide screening rates, relying on specific measures. So mammography is one exam within a 24-month is commonly used. Colon cancer is either a colonoscopy or a stool every 10 years, or a stool blood test every 11 to 18 months. That gives you a little interval to get that patient up to date. I think using 12 months is really not a fair quality measure because at 11 months they're not up to date, and at 13 months they're behind. So you need to give yourself a little interval to get these patients up to date. As you know, and I don't have to tell you, some of the commercially available EMRs aren't all that good at capturing data, and you have to make sure you're entering the data in a searchable format. This is particularly challenging for the colonoscopy done 9 years ago. You have to make sure that this was entered appropriately. Stool testing ordered through a central lab is easier because it'll generate an order. Number 4, you need to involve your entire team. Anybody needs to be empowered to hand out kits. The finest model in the world of this is Kaiser Permanente in Northern California, where anybody in the entire healthcare system is empowered to give a patient a fit test. So we have visits to dermatologists and orthopedists who have saved lives because they were given a fit test by the person checking them in for the visit, and that's true. So the more innovative you can be about this, the better. Obviously, you then need an interprofessional care team to put together an open access colonoscopy program, dedicated phone line. You don't want to wait through the same phone tree that the patients are waiting through. We've put this in place in Jefferson, works well. Everybody should know what their responsibilities are, and ideally the wait time for colonoscopy should not be too long because you'll lose momentum. Same thing with the stool blood testing. Your medical assistants, staff members should know how to give instructions, provide materials, monitor return rates, and make sure people who test positive get colonoscopy, and then you need a system to get people in every year. Hard work, nothing easy about this. Nothing gets done unless you're measuring and reporting, so you need to have a way to assess and report screening practice rates, practice-wide and clinician-specific. You have to report. Good news is colorectal cancer screening is essentially on every large measure. It's a HEDIS measure. It'll be part of macro, I'm sure. So colon cancer screening is going to be part of the way you're measured and part of the way you're paid. And frankly, that's going to be a big help to keep getting rates going in the right direction. So I'm just repeating a little bit that you do need to find who's not up to date, what we call the gaps, the care gaps, and find a population-based management. Now, in large practices, this could be referred to a central group. That's what's done at Geisinger. They actually have people who gather data for all the practices and make outreach letters, write outreach letters and calls, but you need some form of outreach. We've done testing at the American Cancer Society on the messages that motivate people to be screened, and we found that affordability is the largest barrier, lack of symptoms, a lack of a family history, the test is not pleasant, doctor didn't recommend it, no surprise, and it just wasn't a high priority. Those are the barriers to screening, and we then found through research 3 messages that motivated people to be screened. One, there are several screening options available, including simple take-home options. Take-home is very important to the message. Talk to your doctor about getting screened. Number 2, colon cancer is the second leading cause of cancer deaths in the United States, and that turned out to be something people did not know when men and women are combined, but it can be prevented. This emphasizes the prevention message, which is appealing to a lot of people, or detected at an early stage. And third, preventing colon cancer or finding it early doesn't have to be expensive. So this hits on this issue of affordability. There are simple, affordable tests available. Get screened. Call your doctor today. Physician recommendation. Most of you will need to rely on colonoscopy every 10 years or FIT annually, but we did go over some other options that can be used. Make sure patients testing positive have a colonoscopy, and do not rely on the digital rectal. If you've never gone on the NCCRT website, I strongly encourage you to do this. We have amazing tools available for every system there is, your hospital, your colonoscopist, community health centers, primary care physicians, patients themselves. So go on there and see our tools. So as we wrap up, let me just address this question. Are we actually going to reach 80 by 18? So here's what we know. This has been, we believe, the most successful public health campaign of its type in history. I think it's different, quite different than a vaccination campaign. This is trying to reach 26 million unscreened people who have no interest in being screened. And as I showed you at the start, we are actually moving the needle nationally. We're moving the needle in federally qualified health centers. Because these data points are delayed, we actually won't know if we made it until 2020, but we're very excited about the first wave of indicators. I want to emphasize, however, that no matter how close or how far we make it in 2018, even if we reach 80-18, we're going to keep going. We need to stay focused to maintain and continue making progress beyond 2018. And as I tell everybody, we will continue to go as fast as we can, as long as it takes to save lives and achieve something amazing. The goal is big, but the potential impact is extraordinary. And I ask everyone to memorize these numbers. If we achieve 80 by 18, we will prevent 277,000 cases of colon cancer. We'll prevent 203,000 deaths from colon cancer. We'll do that all by 2030. That's over 1 million lives prevented by the turn of the century, which really would be a moonshot, and colon cancer would no longer be the second leading cause of death. Cancer death, it could be as low as 5th or 6th. In Pennsylvania, we have over 1 million additional people who need to be screened to achieve 80%. And if we do that, we'll prevent an additional 8,000 deaths in the next 14 years, which is spectacular. And frankly, there's very few things in all of medicine that can prevent as many deaths reliably as colon cancer screening. It's going to be a big work. It's going to rely on all of you, but I can see it. I believe we can do it. Thanks so much, and we have some time for questions. Kate, I'm going to give you back to presenting.
Thank you so much, Dr. Wonder. Wonderful presentation. As shared, if you do have questions, please type them in the chat box into the Q&A and address that to all panelists so that we will be able to see your question. Dr. Wonder, we do have one question that is in the chat box. Can ADR be identified with FIT, or is this only with colonoscopy?
Now, this is exclusively a measurement for it's a quality measure for colonoscopy. So the denominator is the number of colonoscopies, and the numerator is the % of patients where at least one polyp was found. Now, interestingly, and a little bit unfortunately, some colonoscopists were saying, okay, I found my one polyp, so that counts as, you know, a complete ADR. But there's now work being done on what percentage of patients you should actually find 2 or more polyps, because we don't want people to just be satisfied in finding one. Many people have multiple polyps. But no, it's not a quality measure for FIT. It's only a quality measure for colonoscopy.
Thank you. We have another question. How is this information being communicated beyond family practices, like gynecologic practices?
Yeah, thanks that's a great question. And one of the things I'm really actually excited about is leadership we've had from the OBGYN community. We have a real champion who represents ACOG on the National Colorectal Cancer Roundtable. I spoke at the ACOG national meeting, and I think it's fair to say that particularly because we don't have to be doing pap smears so frequently, the office primary care gynecologists have been eager to find another cause that they can champion and take up, and many of them have realized what an opportunity they have to increase colon cancer screening. Now, if you said to me, is that universal? Are all gynecologists on board in doing this? Well, you know the answer to that. The answer is no. One of the real challenges we have in the United States is for the many practices who are in small group practices or practices that are not part of a large system, quality improvement is often disseminates more slowly. It's harder to reach those practices. Those practices that are part of a large system, part of an accountable care organization, it's easier. So I think it's a bit of a good news story in that we've had some wonderful champions among the gynecology community. I think to the extent that each of you can be a catalyst for change in your medical staffs and in your communities, and make sure that you include everybody who has the opportunity to promote screening, the better will be. So don't hesitate to step up and be the change when it comes to colon cancer screening.
Great. We have another question that came in. If you could comment on the USPSFS recommendation to use Cologuard every 1 to 3 years.
Yeah, it's a great point. And, you know, at the American Cancer Society, we have a very good and close relationship with the task force. There are some firewalls in place. We do our guidelines independently, but we do work very closely with them. In fact, we relied on the same evidence review in what we're doing. We just supplemented it with some data of our own. And just so you know, Kate, for some reason, I can't actually see the questions. So I just keep reading them because I can't actually see them. We actually, in their first draft, they hadn't really recommended Cologuard, and we actually gave some feedback, as did others. And in their final draft, lo and behold, they did add Cologuard to the list of recommended screening options, which I think was the right thing to do. As I mentioned, the ACS had added it to our guidelines earlier. And it certainly is a sensitive test. Here's the problem, and you hit the nail on the head. There has not been a good trial of intervals, whether it should be 1, 2, or 3 years. So that the task force called for, I want to make sure it was a task force, I believe it was a task force, called for the company to do a study comparing 1- and 3-year intervals. It may have been Medicare who called for that, but called for a study that called, asked them to compare this. It may have been Medicare because they had some clout when it comes to coverage. So it's only paid for every 3 years right now. I just don't think every 1 year is practical unless it gets approved for payment on an annual basis. It's one thing to recommend every 1 to 3 years. It's quite another to not be approved for payment. But I don't know of many companies who's going to pay for an annual stool blood test. And I can also tell you that the cost effectiveness of doing an annual stool blood test that's $500 per test, now granted, I think they would probably lower the cost if it were annual, but it tests poorly in models. It doesn't look like it's a good cost-effective approach. So right now, I believe it's an every 3-year test. In fact, there are some models that compare the effectiveness in terms of deaths prevented with an annual FIT versus an every 3-year Cologuard, and the annual FIT does just as well. It may even do a little bit better. So I think Cologuard's a good test for the patient who has the test covered, but doesn't want to do a test every year, only wants to do a test every 3 years. We don't know if that'll outperform FIT, but it's probably a pretty good option.
Great. So another question came in. So PCP should not rely on Hemoccult testing in offices at all to check for blood in rectal exam when symptomatic.
Oh, no. Very important. Thank you for that clarification. And I think this has been a point of confusion because the screening community keeps saying don't do the rectal exam. And that's not my message. If your clinical judgment says I need to do a rectal exam to check for the presence of blood, and certainly in the patient who has symptoms or said that they had a dark stool, absolutely you should do a rectal exam and check for blood as a part of your diagnostic workup. If you want to, for men, examine the prostate, do the rectal. What I'm saying is that's a clinical judgment that has nothing to do, nothing at all, with colon cancer screening. The rectal exam is not recommended for colon cancer screening, and it's not approved for it, and it's not paid for colon cancer screening. It cannot be billed as colon cancer screening. I know that's done, but it's done inappropriately, incorrectly. It would be technically fraud to bill for screening based on a rectal exam. So it's not screening, but if you believe it's clinically indicated, just the way you always would, you should go ahead and do it. Yeah, that's it. That's all I wanted to say about that.
Thank you, Dr. Winder. Are there other questions from the group? One of the things that I will share, just we've gotten a couple of questions in regards to the next in this series, which is a perfect follow-up to today's message and really kind of diving a little deeper into how to kind of put this into practice, how to increase rates in practice. So that will be on February 21st, and of course, if we could include as many folks in that messaging as possible, just like today, we of course encourage that. So in follow-up to today's call, based on your registration, your email address was included in there, we can share that information directly with you. In addition to other things around even accessing today's recording and other tools that were discussed today, we can also share in that follow-up. Other questions from the group?
So, Kate, if I can just make a final comment, perhaps, and if any questions come in before I'm done, great. But if not, maybe this can be the final comment. I've been involved with efforts, and by the way, I see a few names here who've been working with me through the years. I've been particularly involved in the state of Pennsylvania through our CDC grant for many, many years to try to increase screening rates in Pennsylvania. We're a state with a relatively high disease burden for colon cancer. We face some real obstacles. We have some very poor urban areas where, as you know, we have a large number of people who live in rural areas. Availability of colonoscopy varies. My one kind of call to action for our state, and I know we have some people listening from some other states, is that I have been to states that where the whole state has embraced what I would call a really well-oiled, organized, statewide call to action. And thanks to the leadership of Kate and many others in the state and folks from the Comp Cancer program, we're getting there in Pennsylvania, where we really have a statewide roundtable for colon cancer screening. But I know there's more we can do. I think this work happens kind of system by system, hospital by hospital. And I think even if all you do is meet with your favorite gastroenterologist and say, you know, this is something that we should be leaders in. I'm so struck by a small county in rural Ohio where a colorectal surgeon just decided he was going to be, named Michael Sarup, be a instrument of change, and he has revolutionized colon cancer care throughout that entire community. The hospital's become a referral center. They have incredible screening rates. They have incredible quality for their scoping because they've measured it. That's what it's going to take for us to really save as many lives as we possibly can. So in addition to all the great work you're doing in your own practices, make a call to one or two other people if you haven't already done it, and see if we can really engage every system and every hospital to be a leader.
It's a great call to action. Just one final question did come in regards to some of the resources discussed today, including, and I'll just share again, around the today's recording and slide deck and all of that will be shared at a later point, and exactly where that will be housed will be given directly to the audience today from a communication from me based on your registration. So that will, of course, be coming. And I'll just ask if, again, as in the beginning of the call, after today's presentation, you will be prompted to take a survey, just asking some questions in regards to today. That will also be needed for you to receive credit for today's webinar. So we will ask, of course, for you to complete that. And if you do have any questions, you can reach out directly to me, and I will type my name and information into the chat box in closing. But certainly, if there's any final questions, we would want to get those answered. So kind of let's try for that. Okay, well, certainly thank you, Dr. Wonder, for a fantastic presentation filled with great content. And, you know, as you had shared, hopefully we can continue this message and really look to every one of us to be a part of that message and putting it all into practice. So thank you, and thank everybody for being with us today.
Thanks, Kate.
Thank you.